Hello, my name is Dr. Gordon Dow. I'm the Chief of Infectious Diseases at the Moncton Hospital. We're here today to talk about a very, very rare circumstance. We're here to talk about a condition called Creutzfeldt-Jakob disease. We normally abbreviate that name by calling it CJD. Now, CJD is a very rare disease that occurs in the community at a rate of 1 in a million people. This disease is a dementia, and the dementia is caused by an abnormal protein. It's not an infection. It's due to an abnormal protein. We had a patient who lives in Moncton who was admitted to our hospital in December, who was subsequently diagnosed by one of our neurologists with CJD. What is even more rare is that within 6 weeks of this gentleman being diagnosed with CJD, we identified a second case of CJD completely unrelated to the first case. Even more unlikely is the fact that both of these patients had undergone cataract surgery weeks before their diagnosis of CJD was made. We identified 103 patients who had been potentially exposed to instruments from that index case. Now remember, again, those instruments would have been properly handled, and we can't say who would have been affected because there are 16 different trays of instruments. Now with the second case, the number is higher. There were 601 patients potentially exposed from the second case of CJD that we identified. So why would we have two patients occur so soon after one another in one hospital? And when we scrutinized this, we could not find any reason for this except for statistical probability. It just so happens that two rare events occurred at once, and these things do happen. The other question here, is there any chance that the instruments used on the first case could have caused CJD in the second case? And we can very, very solidly say there's no linkage. And the reason we know that is our second case had already developed the early signs of CJD before their surgery and was diagnosed with full-blown CJD very soon after their surgery. When we identified the first case and identified that cataract surgery had been performed on that patient before his diagnosis of CJD, we made arrangements for the cataract surgeon to call each and every one of those patients. They were spoken to personally. Those patients also received a letter just describing the fact this is a very low risk event, but we wanted to keep them informed. And we also sent letters to their family doctors so that the family doctors were aware. Now, when we had the second case, when there were 601 patients exposed, we could not have a ophthalmologist phone all of those patients. The risk of CJD transmission is very low for eye surgery because the protein or the abnormal protein that causes CJD does not appear to be present in any significant amount in the front of the eye, which is where cataract surgery occurs. And probably it is mainly for that reason that it's never been associated with cataract surgery. There's probably a second reason as well, and the second reason is we don't see CJD being transmitted on instruments now that we're using modern cleaning and sterilization techniques. Transparency is very important in medicine. Even in situations where there is low to no risk, letting people know what happened to their care is very, very important. The second reason is we don't know what the risk is. The risk looks like it's zero, and if it's not zero, it's too low to measure. So wouldn't it be appropriate to be vigilant with patients who were exposed to these instruments. The risk is probably zero, but we don't know it. Let's put an alert on the patient's chart so that their healthcare providers know that this very unusual event occurred. There's probably no risk to the patient, but let's scrutinize these patients closely. Let's look at them so that, one, if they show signs or symptoms of a condition that looks like CJD, that people are going to take an extra careful look at them. The other reason you would want to do it is if any of these patients were to undergo operations on the central nervous system, you would want to screen them for CJD first to make sure that there was no risk of contaminating instruments. So what we did do is we looked at what guidelines did recommend, and what they recommended is that in future, when you have patients undergoing cataract surgery, you should make sure that the tray of instruments used for those patients should be matched to the patient. So you know which tray was used on which patient, number one. And number two, you need to ensure that instruments in one tray never migrate to another tray. So we brought both of those things in, and if that is, and now that we have that protocol in place, should this ever happen again, instead of 700 and some letters going out, you would just be sending out a letter to a very, very small number of patients who were exposed to those instruments.